Good afternoon. My name is Jennifer Taff and I'm the Director of Alumni Relations here at Trinity College. I'd like to welcome you to Inspiring Ideas at Trinity with this week's speaker, Professor Linda Hogan. Before I introduce Linda, just some technical points to note first. If you are joining us on Zoom, you can enter full screen mode from the top right-hand corner of your screen. You can adjust your audio settings on the bottom left of the screen, and importantly, in the middle of that panel, you'll be able to ask a question, which Linda will answer at the end. If you're watching us on YouTube, the navigation panel is at the bottom of the screen, and you can ask a question in the comments section. This webinar will last for approximately 1 hour. Linda will give a presentation for half an hour, and then we'll have questions and answers. The webinar is being recorded for future viewing. And now on to the main order of business for today. Linda Hogan is Professor of Ecumenics here at Trinity College and founder of the Trinity EthicsLab. From 2011 to 2016, she was Vice Provost, Chief Academic Officer and Deputy President. An ethicist with expertise in social and political ethics, she has published extensively on a range of ethical issues. She's been a member of the Irish Council for Bioethics and a board member of the Coombe Hospital, Science Gallery Dublin and the Marino Institute of Education. She's worked on a consultancy basis for a number of national and international organisations developing their ethical infrastructure, and we're very pleased to have her here today. Linda.
Thank you very much, Jennifer. It's a great pleasure to be here and to participate in what has been a very interesting series of webinars to date. Just going to share my screen so that we can begin the session. As you can see, I've entitled the presentation, The Ethical Response to COVID-19, Who Decides and Why It Matters. And of course, the coronavirus raises many difficult and serious ethical issues for individuals and governments, for healthcare practitioners and patients, and for local populations and the global community. And of course, we know these aren't abstract issues either, but each really does have a human face, whether it's the elderly patient denied access to a ventilator or overworked healthcare workers trying to make impossible, ethically laden decisions, or impoverished day laborers in India, for example, for whom social distancing is a luxury that they can't afford. Among the most pressing issues that we encounter are, for example, in healthcare settings, issues of access to treatment versus rationing and on what basis. Should access to ventilators or clinical care beds, for example, be limited to those who are young or with no underlying conditions? Who decides and on what basis? Do healthcare workers have a duty to treat during pandemics, even when they're putting their own lives at risk? If so, what are the limits? What about the duty of care to healthcare workers? When we think about managing pandemics in a technological age, here really technological utopia meets health. Many societies around the world have already begun to develop COVID tracing technologies. What are the ethical principles that should guide their development and deployment? Are we seeing the evolution of surveillance societies driven by fear, where people may be prepared to forego important civil liberties in exchange for stability? And are there downsides to this? In relation to mandatory public health initiatives, should the public be coerced into public health interventions, for example, quarantines or mandatory vaccination programs? What's the balance between individual autonomy and the common or public good? The ethics of clinical trials are especially important, especially challenge trials, where speed might be trumping safety, or where there may be issues of compromised consent. And also, obviously, in the context of social justice, COVID-19, as we've seen, amplifies existing inequalities, both within economically developed countries and between different parts of the world. How should issues of social justice and inequality be addressed in the context of this crisis? Whether we're talking about day workers in India, refugees, or people in IDP camps, or indeed in countries like the United States and Ireland, where existing vulnerabilities like disability, homelessness, etc., can determine access to healthcare. So I'd like to end my presentation later with a question about whether the crisis can be a catalyst for addressing some of these issues of the growing inequality within and between nations. Why does ethics matter? Well, this afternoon, I'm really just scratching the surface beneath some of these issues. And of course, there are other ethical issues related to COVID that we can't even touch today. Ethics matters, I think, first of all, because it's vital that the public has a role in debating and ultimately endorsing the ethical principles and priorities that guide our societies as we continue to grapple with COVID-19. Because this consensus is essential not only to guarantee trust in healthcare and the government response to it, which can really only function in exceptional circumstances when there's trust and solidarity in society, but also it's important because it holds up a mirror to existing inequalities, and it has the potential to reinscribe existing inequalities, create new ones, or, as I said already, be a catalyst for some kind of social and political transformation. When we look at the COVID crisis through an ethical lens, in order to determine what the ethical approach might be, we bring to bear a variety of considerations, principles and duties, consequences and outcomes, virtue, character, intention, etc. I promise I'm not going to give an introductory session to ethical theory here, but really what I want to say here is that each of these categories represents a philosophical theory that prioritizes either a duty and principle, or outcomes and consequences, or personal virtue and character. And each really reflects a different perspective on human beings in society, and the nature of the good. Today, I think most scholars would recognize that some kind of pluralist approach to theorizing, moral theorizing, is important, because there are very few ethical issues that can be determined through one simple lens of duty or consequences, for example. In fact, most of the serious ethical issues that we encounter is precisely because good outcomes can only be achieved at the expense of fundamental principles, or vice versa. So ethical responses to the COVID crisis requires deliberation, a process of ethical reasoning to determine the right and the good in each situation. So here I really follow Aristotle, who called this process of ethical deliberation phronesis, or practical wisdom, which requires both good judgment and what he would have called excellence of character, in order to determine the right and the good in each situation. So in this short session, I want to discuss some of the ethical issues that arise, as I mentioned, in the context of healthcare, contact tracing technologies, mandatory public health initiatives, and broader issues of social justice. The purpose today really is to shine a light on some of these issues in order to prompt discussion, rather than allowing for a deep consideration of some of these very complex issues. So I'm going to work through each of these in turn, talking briefly about the ethical issues at stake and how they might be resolved. Let's begin then by looking at the issue of ethics and healthcare in a pandemic. Now, the ethical use of scarce resources is not a new problem, but actually COVID-19 has propelled this issue into public consciousness with new urgency. In situations like this, of course, every effort needs to be made to increase medical capability, and also it's reasonable and prudent that healthcare workers be given accelerated access to resources in recognition of their importance for the common good. Yet even with these issues in place, decisions about the just and equitable distribution of available medical resources often needs to be made. It isn't possible to validate many of the stories that emerged during the COVID-19 crisis, but we do know from the news and other reports from Northern Italy, from Spain, from New York, from Brazil, and many other places that health facilities were overwhelmed and healthcare professionals had to make very difficult decisions about who would be given access to critical care beds, to ventilators, or other scarce resources, and on what basis. And even where healthcare systems were not overwhelmed, the prospect of further waves makes clarity about which principles should apply and which principles should guide access to resources essential. The immediate response is often, well, access to scarce resources should be driven only by clinical factors. A variation of this principle is that we should be selecting only the patients most likely to benefit from the treatment, since this is the best way of saving lives. And of course, it's difficult to argue with that at a simple level, but very often, of course, clinical factors don't sufficiently allow us to differentiate between patients so as to be able to make that the primary discriminating factor. But in addition, while the idea of selecting the patients most likely to benefit might seem reasonable, embedded in this concept often are systemic biases that disadvantage groups who, even without COVID-19 infection, experience worse health because of historical and structural reasons. And this can include racial minorities, the social and economically disadvantaged, and to a certain extent, the aged. So these seemingly simple formula that clinical factors or patients most likely to benefit, while they seem simple, actually they risk introducing discriminatory elements that are based on existing inequalities. So when we look at this question, whose treatment should be prioritized, we have multiple but competing ethical obligations in play. There's the duty of care. There's the duty to steward resources to optimize public and population health. There's the principle of fairness. There are the principles of equality and equity, non-discrimination, inclusivity, and the principle of distributive justice. So we have to determine how these competing principles can be balanced when decisions to provide or not provide access to resources, and only when that is an inevitable issue. Now, many jurisdictions and health systems give guidance on this. Some of the guidance is very general and vague. Other guidance is very specific and detailed, including score sheets that determine access to treatment. Today, however, I just want to sketch the shape of a response, at least from my perspective. When we're moving to the resolution of such conflicts, I think the first thing to say is that the clinical determination can and should, of course, play a role insofar as it is relevant for the prognosis in relation to the specific pathology. And the patient's age can also play a role in the prognosis. However, comorbidities, frailties, age, etc., should not and cannot be generalized as criteria for maximizing the efficient use of resources. Explicit age-based criteria should not be permitted, and there should be no use of categorical principles in themselves, categorical exclusion criteria. That is, all patients should be regarded as eligible to receive critical care treatment. I think the principles of justice and equality require that the most individualized assessment of a patient's prognosis that is possible to determine, which is possible to determine in the circumstances, needs to be attended to. It is, of course, I think, ethically legitimate to presume that comorbidity, frailty, or even older age can adversely affect therapeutic outcomes, but only in circumstances where it's no longer possible to determine the urgency and prospect of success of intensive care treatment in several patients admitted at the same time. So I think this approach to the healthcare system is committed to the principle of the dignity and well-being of each individual patient, regardless of age, comorbidity, frailty, etc. And I think it's this core principle that must be preserved, even when individualized treatment sometimes, unfortunately, leads to differences of care based on relevant factors. But even when these criteria appear to reflect principles of fairness by explicitly excluding categorical considerations of age, ethnicity, comorbidities, etc., this approach still risks being discriminatory because we know very well that health status is deeply affected by socioeconomic status, that life expectancy differs significantly across groups, often associated with historic and structural disadvantage, that access to routine healthcare is often a function of socioeconomic status. So these background conditions, although explicitly excluded from the immediate decisions about access to critical care and other scarce resources, nonetheless, these inevitably feature when issues like life expectancy, comorbidities, and other factors are assessed. So in these contexts, the traditional bioethical focus on individuals is really not sufficient. Rather, access to treatment also needs to be conceived of as an issue of social and political ethics, rather than only or as exclusively as a matter of clinical ethics. So the concept of the dignity of the individual, or the concept of individualized assessment, looks quite different when viewed through the lens of systemic inequality. So while it is unreasonable, I think, to expect clinicians in emergency situations to compensate for the effects of embedded inequalities as they make clinical determinations about access to scarce resources, nonetheless, I think these issues must be included in the post-pandemic analysis. And in particular, as health systems plan recovery frameworks, the disproportionate impact of COVID-19 on the socially and economically marginalized communities and individuals ought to be addressed. Now, once the immediate health crisis has been managed, many governments then turn their attention to measures that can reduce the ongoing spread of the virus. And in this regard, track and trace apps have already played an important role in addressing the spread of the virus. So the question is, how can such technologies be ethically deployed to contain the spread of the virus? And which ethical principles should govern the gathering, use, and storing of the sensitive personal data that's gathered? Although innovations here have been hugely positive and hold great promise, there are indeed ethical concerns associated with the use of these technologies. And actually, the ethical discussion is already very well rehearsed because many of these technologies are already in use in contemporary life. The ethicists and citizens are concerned with threats to civil liberties, the magnification of bias and discrimination. They're concerned about political manipulation and lack of transparency. There are also concerns about the extent of the data collected, about the possibilities of modeling and triangulating data, and also about their predictive capacity. Indeed, long before the COVID crisis, the Berkman Klein Center for Human Rights did a very extensive report looking at the impact of a range of tracker technologies on human and civil liberties. human rights and civil liberties. And they concluded, it's there on your screen, here's a quote from the text, in relation to the rights to equality, free expression, association, assembly, and work, their impact has been more negative than positive to date. But we're in a new situation in which individual and public health benefits of tracker technologies are tremendous and hold very considerable promise and hold great opportunities for us. Indeed, they provide opportunities that previous generations who faced epidemics didn't have. So we have to balance the benefits of using these technologies with the concrete and particular values that they need also to protect. And in this context, some of the EU's guiding principles are very useful. They provide a touchstone. The EU's fundamental values of respect for human autonomy, prevention of harm, the rights of freedom, non-discrimination, and equality, etc., provide an important baseline. We have had a very interesting and very good report from CFAR, which is an NGO, a Canadian NGO that gives advice to the Canadian government on such matters. And they produced a very interesting and very insightful report recently called Science, Technology and Ethics in a Pandemic. And they identified what they see as the key ethical principles that should guide the use of tracking technologies. I'll just go briefly mention each of these. First of all, obviously, transparency and accountability. Citizens need to be clear about the objectives and the limitations of any technological applications here. Governments need to clearly explain the role of particular technologies and their contribution to public health. We need systems of accountability, a pandemic legal framework, and of course, independent oversight mechanisms that can report on publicly and in real time about the effectiveness and impacts of the technologies. Privacy is very important. In Europe, we have GDPR, which is very important and good in these contexts, which really have set up a situation where we have privacy by design, really, technologies that incorporate privacy preservation measures within their design. Those two need to be very much part of the ethical use of the technologies. Equity and diversity is also an important principle. The lack of access to technologies and unrepresentative data risks creating new or exacerbating existing inequalities. Because access to technologies such as smartphones is not equally distributed, and where there is then an over-reliance on the data collected in order to determine public policy, there needs to be, care needs to be taken with that. It's very important that what we call the digital divide is recognized, especially when we have data-driven public health responses. The digital divide can be a generational one, as well as one that might be socioeconomic or ethnic in character. But technologies that gather data and use that data in order to determine public health responses need to be very attentive to the issues of equity and equity of access to these technologies as they are being deployed. Necessity and proportionality. Obviously, interventions of these kinds need to be proportionate. The invasiveness and the scale of their deployment should be proportionate to the public health needs that are being addressed. And of course, clear limitations in terms of sunset clauses, the management of the data and the clarity about what the data can be used for and when it will be destroyed, etc. All of these are essential. And then just finally to mention quality, security, and efficacy. There's a lot of debate about these principles because these principles sort of tend to insist that the design of novel technology should be evidence-based and the regulation should be evidence-based. And many scientists argue that that's a brake on innovation. The precautionary principle that the EU has adopted, for example, in relation to many of these technologies, not only in relation to data technologies, but also in relation to biomedical technologies, is often regarded as I said, a brake on innovation. But nonetheless, I think the precautionary principle is important because it insists that where scientific evidence about environmental or human health hazard is uncertain and where the stakes are high, the precautionary principle should apply. In relation to public health programs, many similar ethical principles discussed in relation to tracker technologies apply, so that the values of autonomy, equality, the principles of fairness, non-discrimination, proportionality, etc., all provide an important baseline. However, when compliance is mandatory, an additional ethical threshold, I think, applies in terms of these principles, particularly where individual rights and freedoms are being relinquished in the service of the public good. In these cases too, I think it's important to remember that interventions like mandatory quarantines affect socioeconomic groupings differently, so that vulnerable populations like IDPs, refugees, day workers, etc., can often carry a disproportionate burden of the individual sacrifice vis-a-vis the public good. So this too, I think, needs to be kept in mind. Here, I think the central question is, what do we owe each other? And how do we make sense of that in the context of balancing individual rights and the common or public good? In democratic societies, where a high value is placed on individual freedoms and rights, the ethical burden, of course, falls to those who seek compliance with mandatory interventions. But individual freedom and personal autonomy are important ethical values, not least because of their fundamental role in allowing each person to be the author of his or her own life course and his or her own well-being. But of course, they're not absolute values, but they exist alongside other values like respect for dignity, community, equality, health, and other aspects of human flourishing. Pandemics really do underscore our interconnectedness, and they often require curtailment of individual liberty for the common good. But interventions should be proportionate, time limited, subject to democratic accountability, like those measures that I described in relation to the contact tracing apps, and also accountable to the rule of law. So I see individual freedom as a fundamental value alongside other values like solidarity. And in times of crisis in particular, civic virtue and solidarity become even more important. Now, philosophers of liberty have given various answers to the question of whether and on what basis individual liberty should be limited. And I think balancing individual rights with the common good is really a matter for public discussion and debate. And as I said, it is important not only in relation to public health interventions, but also in relation to the final issue that I want to discuss today, which is about the question of social justice within and amongst nations. As I just mentioned, the interconnectedness that requires individual liberty to be curtailed within limits, of course, for the common good is also vital when we look at issues of social justice. We've already discussed how the COVID crisis amplifies existing inequalities, both within economically developed countries and between different parts of the world. many vulnerable individuals and communities bear the disproportionate impact of the crisis in terms of quarantine, job losses, dependence on social welfare, as well as in relation to health status and social inclusion. So as we think about ethical responses to COVID-19, I think the issues of social justice and inequality begin to loom large. In addition, some of the political responses to the COVID crisis, which have been often nationalistic and racist, tend to continue a recent pattern which has been intended to disrupt the fragile moral consensus that has reigned in the post-war period. Because already, indeed, more than 4 or 5 years ago, we have seen that the politics of fear has been gaining ground, much of it driven by the economic inequalities and the destabilizing changes of post-imperialist globalization. So we've seen a new intolerance even in previously tolerant and democratic societies. So claiming one's voice and recognizing that each person counts for one and no one counts for more than one. These really have been principles that have shaped the normative and ethical commitments of the post-war political order. But if we take a historical and political analysis of the last 70 years, unfortunately, it reveals that these normative commitments are honored more in the breach than in the observance. And also, even while these normative commitments to equal dignity and rights were being formally adopted by governments around the world, the economic policies that would support the realization of social and economic rights were being discarded or overridden. In a wonderful book called Not Enough by Sam Moyn, he shows that instead of the global justice that was initially bound up with the post-war ideal of human rights, in fact, market triumphalism has triumphed, and human rights were cut off from the dream of globally fair distribution. So the problem, therefore, has not just been one of unrealized promises, but rather it's been about the abandonment of one of the fundamental dimensions of the human rights agenda, namely the complementary commitment to distributive and social justice. And therefore, there's been a hollowing out, as Moyn says, of human rights values by market fundamentalism. So as I conclude my overview of the ethical responses to COVID-19, we've moved from clinical ethics to technological ethics, to public health ethics, and to political ethics. Throughout, in a way, what I've been suggesting is that there's a question about whether the COVID crisis will reinscribe and highlight and amplify existing inequalities, or whether we will be able to take this historic opportunity to address some of these issues. So can COVID-19 be a catalyst for a renewed commitment to equality, equal dignity and respect, for a politics of empathy and solidarity? That is, can it be the grounds for hope in a divided world? Well, I think only time will tell, and I look forward to hearing some of your responses to that question as we have our discussion. So thank you very much.
Linda, thank you so much for that. It was so interesting. There's so many questions I'd like to ask you myself, but we've got plenty coming in, so I will go to those first. We've had a few people asking similar questions in a different way, and then we've had people asking questions coming down on either side. If I go to the sort of young versus old aspects of COVID-19 first, one person has asked, we've once again prioritized the elderly over the young. Would it not be more ethical to do the opposite? By the same token, we've also had, and maybe they don't contradict one another, but we've also had somebody saying, Do you think that the government regulations around the cocooning of the over 70s was unethical and discriminatory, or necessary to help prevent the spread of COVID-19? So that the young versus old issues.
Thank you very much. Very interesting questions. And in a way, okay, although they're framed in terms of young and old, they're actually, I think, two different questions. The first one about, once again, we've prioritized the elderly. I don't think that's quite true, well, quite correct, but really, I suppose the core of my argument when I was talking about this issue is that I think there's a fundamental error in using these categories like elderly, young, etc., whether it's about race, ethnicity, or about age, that actually is a fundamental flaw. Inevitably, we go immediately to the categories that we're familiar with. But actually, I think if we begin with the issue, with the perspective that there are no categorical exclusions in terms of age, in terms of health, etc., then it can allow us to make certain distinctions on the basis of individual assessment rather than in relation to categories. I think we see this very particularly in relation to actually the cocooning of elderly people, because if you remember, it was the over 70s and there was a debate about whether 70 was the right age or whether it should have been 75, etc. And in a way, I think that brings us to a fundamental ethical problem rather than a resolution of the problem. My view on that issue was that there should have been a clarity for all the population, including the elderly, about the risks that they were running. The elderly were not disproportionately likely to spread the disease. So it's really about the risks they run themselves in the first instance. And I think allowing individuals to take risks for their own health, if they are not jeopardizing the health of others, is a reasonable thing to do. Now, at the early stage of the pandemic, where there was a real risk of the critical care beds being overrun, I think in that period it was not discriminatory and it was reasonable to ask, which actually is what the government did, ask the over 70s to cocoon, because they were at greater risk of becoming seriously ill if they contracted the disease. So I think that, again, it's about making these nuanced judgments in relation to being agents of spreading the disease. I think where somebody is elderly and well, they're less likely to spread the disease. So I think in those cases, there should not be such a requirement in terms of cocooning. But in the early stages, when they were likely to be those disproportionately needing critical care beds and therefore likely to put an additional burden on an already stretched system, I think that was a reasonable and ethical position to hold. But of course, I'm sure other people would disagree with that.
We've had a question in from Professor Jane Grimson of this parish. I'll read it to you now. Dame Nora O'Neill has written extensively on the issues of trust and informed consent in healthcare. During the pandemic, governments are making far-reaching decisions based on science which they do not understand. The public then have to accept this. The public then have to accept these decisions with no hope of understanding the underlying science. What ethical issues arise in the absence of informed consent?
Thank you very much, Jane. So I think, again, I'd like to take this in a couple of different stages. I think the first issue that is suggested by Jane's question is about trust in science in the context of not only the understanding of the pandemic evolving while it's happening, but also in terms of the public's capacity to understand science, and therefore depending on the experts, if you like, to mediate that science to us. Well, I think the first thing I would say there is that we see in, in newspapers at the moment, public trust in science in the first instance depends on the integrity of the scientific method and on academic integrity in science. And so we have seen a number of different problems already with studies having to be retracted, etc., on the COVID, science related to COVID already. So there's a very big burden that the scientific community have to carry in terms of ensuring that all of their peers are adhering to all of the requirements of the academic and research integrity in science. And that, of course, is true for the vast majority of scientists, but unfortunately, we have situations where then we have the occasional rogue scientist, or maybe it's more endemic than that, but it definitely erodes public trust in science. But the public does have to trust the experts to a certain extent. And that's one of the things that Honora O'Neill has written fairly extensively about, indeed, about trust in experts and why it's important, and why the trust in the institutions of science, in the institutions of government, of media, universities, etc., is absolutely vital, because trust really is a proxy for knowledge. Because the public can't read, understand the science, we have to depend on the trustworthiness of those who are interpreting that for us, mediating it for us, and making assessments on that basis. I don't think that there's a conflict between putting trust in experts and having informed consent on certain issues, because sometimes we have to consent to the judgments of others, because trust is, as I say, a proxy for knowledge. It replaces knowledge, it replaces expertise, because the vast majority of the public don't have the knowledge to be able to make those assessments about whether a particular paper in the Lancet is or is not pointing in a particular direction. So, but I would say that certainly in Ireland and in very many parts of the world, I think what we've seen over the last number of months is the extraordinary public confidence in science and scientists in the initial stages, the way in which scientists have been keen to speak in public, communicate in language that the public can understand. And I think, including very many of our Trinity academics, it has to be said. And so I think informed consent depends on our having trust in the experts and in the institutions that guarantee the reliability of those experts.
A couple of questions in now about health tracking apps and how they might represent the thin edge of the wedge. We have a question from Lenny Abrahamson. Do you think that we in Ireland, who are not as used to our personal details being stored and used by government, such as ID cards, unlike many other European countries, are oversensitive about being traced and contacted? Should public safety be more important to us in this regard?
Thank you. And thank you, Lenny. Yeah, I think you're right that we're not used to our personal data being gathered and used so so comprehensively, although of course it is being gathered and used in ways that we probably don't really know fully or understand. I think what I was trying to highlight there in my presentation is that I don't think that there's a trade-off between, on the one hand, public health initiatives that use contact tracing apps, and on the other hand, you know, our individual autonomy and privacy, etc. I think it's all in the design. And so we've been used to hearing about privacy by design in the many of these new contact tracing technologies, where the concerns about privacy are part of the process of developing the apps and are part of the technology that actually, the platform that is built as part of the, in order to have the privacy respected. But what I think we also need to see is, if you like, ethical by design. And we've talked a lot about this in various contexts in Trinity with the Adapt Center and other places, where it's all in the design and also the deployment of these technologies. It is possible, I think, certainly possible to have the ethical use of these technologies that can be quite invasive, gather a lot of data, but as long as there is proper oversight of the nature of the data gathered, the storing of the data and the use of the data, as long as there is real-time reporting of that, and as long as there's accountability for that, then I don't think that there's a conflict. I think there's also a slight difference with the way in which the apps are currently used. I don't see in Europe that contact tracing apps will become mandatory, for example, in order to, you know, to go out or, you know, have a new normal experience. But in many other countries, especially in Asia, where they're quite used to the use of these technologies, often the use of these technologies is mandatory. So I think where there's the voluntary use of proximity apps or tracing apps, the ethical threshold is a bit lower, but nonetheless, I think there is a balance to be achieved, and I think it's possible, actually, and I think it's possible with proper design, proper deployment, and then proper oversight of these technologies.
Shifting gears a bit, we have some questions in around the theme, are some social gatherings more ethical than others? So one from an alumna Athena Wu, do you think it is ethical to protest against systemic racism whilst risking spreading COVID-19? Would it be better to stay silent and withhold addressing these issues in the name of public health and safety?
That's a great question. And, you know, I've been thinking about this a lot because, of course, these moments come along very occasionally, and only one, you know, sometimes once in a generation, where there's such kind of outrage and collective recognition of an issue that is well known, and you know, where there is a lot of protest in, you know, across NGOs and across the political systems already. So so it's something that I really have been struggling with myself. I think that certainly some gatherings are more ethical than others. So it's like, what's the purpose of the gathering? And actually, I think we've recognized this in relation to even in the quarantine situation, when everybody was expected to stay at home, certain things were permitted in emergency situations, or certain visits or travel was permitted. So it's never been an absolute containment. So the question is whether those individual assessments should apply to more more generally to a political or social context. I would say that gathering to protest injustice at a time when there seems to be a historic sort of breaking point is more ethical than gathering to go to a concert for for enjoyment. There may be times when neither is ethical because of the extent of the public health crisis, but I think, I would assess the purpose of a particular gathering, a particular journey, a particular breach, for example, of general COVID restrictions more ethical than others. So that's where I would come down, but there may be contexts in which it is not ethical, because such is the severity of the crisis at that time.
Okay, thanks. We have a comment, more than a question in here from Deepak Saxena, but I think it's one I'll read out because it raises the question of how governments have reacted and reacted in different ways, and whether they've reacted in line with sort of what they'd be known for in terms of, countries that place a priority on personal autonomy, for example, and how they may have reacted. So the comment is, it seems like the COVID crisis has acted as a catalyst towards what the governments were doing before. EU governments are moving more towards social justice, US, UK, India moving towards an economic focus, China moving more towards authoritarianism. What would you say to this?
It's interesting. I'm sure many people were participating in last week's webinar also about legal responses to COVID-19, and this particular issue was also raised and discussed. And I think on that occasion, the Oren Doyle and the Italian legal scholar said that they too agreed that that was the case, that the trajectory, the direction of travel that governments were on has tended to be reinforced through this crisis. I think that's true. But I also think that what's been happening in the United States in the last number of weeks shows that the direction of travel of a particular government is never entirely certain or secure. And so political activism is a very potent force and can change the direction of travel of particular elected governments. But it is certainly the case, I think, that, and it shows actually how pandemics or any crisis can be manipulated by political power when there's a determination to do so. And I would agree with the comment for sure.
Okay. I'm afraid we only have time for one more question, Linda. It's from Professor Cliona Farrelly. Should we be having an urgent citizens' assembly in Ireland to discuss how we make these decisions?
I presume Cliona is referring to an urgent virtual citizens' assembly. No, I think, Cliona, I would agree that it's absolutely vital that citizens are part of the process of deliberation and debate and consensus building. I think it's particularly the case in Ireland at the moment, where we have a caretaker government which is trying to make decisions in the public good, but without the sort of the certainty of of a political outcome that had seen them put back into power. So I think citizens' assemblies have been extremely potent forces for change in Ireland over the years. I think they're an excellent context in which such issues can be debated and consensus forged on these issues. I would say that really part of what my agenda has been throughout this session has been really to highlight that these are ethical issues and principles that need to be debated regardless of whether we're in the middle of a pandemic or not. They're issues about trust, public good, individual liberty, about social justice, equality, etc. They're enduring issues. They're simply brought to a new point of magnification with the COVID crisis. So I would like to see something like a citizens' assembly, or indeed a citizens' assembly, that addressed some of these issues, because they will last long after we've managed to deal with the virus and contain it, or get rid of it completely.
Okay, well, that sounds like a good note to end on. So Linda, thank you so much for taking the time to be with us today. It's been absolutely fascinating. I really enjoyed listening to you and the questions that come in from everybody. Thank you to everybody who joined us as well. And we could have gone on for much longer. I'll send you all the questions that came in afterwards for your perusal. So thank you very much. And to those of you today who joined us, if you enjoyed today's session and you'd like more from the Inspiring Ideas at Trinity webinar series, please join us next week for Cultural Innovation During COVID-19, How Science Gallery Dublin adapted to a new way of sharing activities and research. We'll be sending out an email about that in the coming days, and we'll leave the details up on the screen now for another few minutes, indeed, with Linda's own webpage there for further information. So thank you all very much and have a good afternoon.